BT199 because that's the one we have most experience. I showed you already this slide a couple of 3 or 4 times, even this one. So as Michael said, we have high efficacy. We have also to pay a price in terms of toxicity, which at the end is not so high. So here you can see the list. You already saw it before. Those are all grades, nothing impressive. Again, diarrhea. This is again, I would call it a ibrutinib-like diarrhea, so not definitely like a dialysis, so it can be easily managed. It's not a major issue, but it affects almost 50% of the people, so one has to be aware of it and warn the patient. The other effect that shows also here among the grade 3 and 4, and it is actually the top one, neutropenia, grade 3 and 4, 1/3 of the patients. And I have to say that these nowadays, we are going to talk about the tumor lysis syndrome later on, and probably this is not a problem anymore. Nowadays, I find this the major problem when treating these patients. So with a lot of stop and go because of the neutropenia, you can add the growth factor, but then after a while, the growth factor stopped working. So that's probably one of the major issues for also decreasing the dose of the drug. And then tumor lysis syndrome, we already heard a lot. I just want to make a summary recap, just to give some ideas. So everything started a long time ago, 5 years ago, something like that, with the first study, the phase 1 study with the BT199. And the first 3 patients that were treated had tumor lysis syndrome. And subject 1, 3, and 4, number 2 was not then treated. So what they did, and these patients started with a dose of 200 milligram, one of them with 100 milligram, because at that time nobody really believed that the drug could have any effect. So they really started with a high dose. You have to know that now the dose that is used is 400 milligrams. So we were quite close to the top of the dose. So they changed a little bit the administration, and they started with 50 milligram. Okay, so instead of 150 milligram, and still we are in 2012, they have 2 fatal tumor lysis syndrome. So at that point there were 2 studies, the phase 1 with ABT199 only, and then the other one already with rituximab, and so these 2 studies, and so both studies were put on hold, and then they came up with a solution. The solution was, and here just to remind you what tumor lysis syndrome is. It's not only the clinical tumor lysis with all the symptoms starting from renal insufficiency, but it's also the laboratory tumor lysis, so the changes in electrolytes and uric acid. So from that moment on, they started checking every single patient for tumor lysis, both laboratory and clinical. This is also to make you understand that you will see a lot of data, not from me, but also in the future in every trial using ABT199, and there will be always a lot of tumor lysis, laboratory tumor lysis, and it's there. So they do see, and they will see movements of electrolytes. We don't know what it means because we don't know what happens with FCR, what happens with rituximab alone. Nobody ever checked so frequently and so constantly the movements of electrolytes in the patient's blood. So, but just to keep in mind that from this moment on, you will always see clinical tumor lysis syndrome and laboratory tumor lysis syndrome. So you have really to understand what's going on here, what is checked. So the concept. What they call the ramp-up period. So they added another phase where the patient is challenged with a test dose, what they call a test dose, that is already effective. In my hands, I see already responses, but anyhow, it's very low, 20 milligram, is probably homeopathic, is 20 times less than the target dose. And if you have no abnormalities in the electrolytes, and in addition, you don't have a quick apoptosis of the cell, so you don't have a quick decrease of the lymphocytes within the first 24 hours, then you can go on the second day, you can already escalate to 50 milligram. Otherwise, if you have electrolyte movements, so at least 2 of them should increase, or if you have no electrolyte movements, but there is a rapid reduction, meaning more than 30% reduction of the lymphocyte, then you continue 20 milligrams for a week. So this is it, 20 milligrams, so practically nothing for a week, which is, I think, is very careful from the company side. We have to think that we are somehow wasting a week. So it might be that in some patients, it's not what we would like to do, to wait 1 week before we have a response. And indeed, because after the 20 milligram, that can be only 1 day if you don't have any laboratory tumor lysis, or it can be 1 week if you have some laboratory tumor lysis, then you still need another week of 50 milligram, another week 100 milligram, another week at 200, and then finally, after more than 1 month, you end up with your target dose. So that I can tell you, it is not an acute leukemia, of course, it is CLL, but still, in some cases, it can be challenging also for the doctor to stay there doing nothing, so with 20 milligram, and while the disease is poorly controlled. So here I show you the two different ramp-up dose. So it can be only 1 day at 20 milligram, or it can be the whole week. So we heard before that the patients are now, in all the studies that you will see from now on, divided in 3 categories based on the risk of tumor lysis syndrome. And so the low risk have lymph nodes that are lower than 5 centimeters with a lymphocyte count lower than 25,000. Medium risk nodes between 5 and 10, or, so either one, lymphocyte more than 25. And the high risk either nodes more than 10 centimeters, or the presence of both intermediate nodes between 5 and 10 and more than 25,000. Of course, you need the CT scan to do the categorization. You need the CT scan and the white blood cell count. So this is one thing. So the patients are divided in these 3 categories, and what you have to do is also you have to administer allopurinol, for example, to all patients, and then rasburicase in the high-risk patients. And then, of course, all patients has to be hydrated. That's also one of the reasons to hospitalize the patient, because you are sure that the patient is hydrated. Because in the prior studies, it turned out that the patient probably, when they were home alone, even if they were suggested to drink liters of water, they didn't do it, or they didn't do it so properly. And so indeed, for all these patients, regardless the risk of tumor lysis, now in all trials, patients are hospitalized, and are hospitalized for the first 2 doses, for the first 2 changes of dose, so a 20 milligram and a 50 milligram. That can happen in 2 consecutive days, or 1 week apart, depending on the thing. For the high-risk patient, instead, you need to hospitalize the patient at every dose escalation. So 20, 50, 100, 200, and 400. Having done that, everything changes, it is true. So now clinical tumor lysis syndrome is not a problem anymore. And you can see it here. So here there is the list of, so you can see the data on tumor lysis syndrome in patients before the change of those modifications. Now instead, this is after the post-modification, and so you don't have any more clinical tumor lysis syndrome, while instead you keep seeing laboratory tumor lysis syndrome. But again, we don't know what that means. We don't know how often we get that with FCR, with ibrutinib maybe, with whatever drugs you can come up with. And so here you can see an image showing that indeed if you divide the patient, if you split the patient based on risk, patient with low risk, they didn't have any tumor lysis syndrome, neither laboratory nor clinical. These are the medium, but in particular, the high risk patient who had clinical tumor lysis syndrome had none, and the risk of even laboratory tumor lysis syndrome was decreased. So it is true that now the drug can be safely administered. So now there is another issue. It's not anymore safety of the patient, it's probably safety of the doctors and on the nurses, meaning that you need to hospitalize the patient. And you need to hospitalize 2 times, 1 week apart, so you must find a bed. And you probably you have the same problem here as we have in Italy. So to have a bed available on the exact day when you need it is usually not so easy. And that can be, I think, a challenge rather than the tumor lysis syndrome. It can be a challenge in treating the patient. So it's probably easier to give a drug orally and send it home. Also, this drug is oral. That's also the funny thing. So you hospitalize a person just to get some liquids into the vein and nothing else. So that's probably the major issue. So thank you a lot. Here are the data and ready for your questions. Yes, please.
So this is the most unthoughtful strategy that this company has gone after. It is absolutely not based on anything. They pulled it out of a hat. And it really makes it very difficult to give this drug. It is also very difficult to imagine that if you have tumor lysis syndrome, it usually means you have ultra-sensitive tumor to the drug. And that's something that I think you're going to see as well as get the counts down within the first week or so, even at the lower doses. So the question is, why the 50, 100, 200? You know, I can understand the 50. I can maybe understand the 100, but I don't understand the 200. And I think the whole thing could be foreshortened as well. But it's just, it really was never looked at. And they've made it very difficult to actually give it.
Yeah.
When there is an amendment in that current protocol that I showed. If you have a patient that you're really worried about who's progressed off of, say, ibrutinib, we actually can shorten the dose escalation. So we're getting some data on that.
What is true, of course, I perfectly agree with you. And I go back to the biology always because that I think is important. So it is true. You might see, if you don't see a response at 50, if you don't see a TLS at 50 probably it's better you go up quickly because the tumor is not so responsive. And you don't care about tumor lysis syndrome, you care about saving the patient. 2 things. On one side, I'm sure that if the product will be on the market, if and when the product will be on the market, doctors will shorten the thing. And the problem is that if you don't regulate that process of shortening, that doctors will create even problems, shortening too early, too quickly, in the wrong category of patient. So that's what probably the company is worried about, because if you have 1 death with this drug who already had death in the past record, then I think would be the death of the drug itself. So I understand that they are very cautious. I also understand that many of the people in this room maybe will change a little bit the schedule depending on the severity of the disease and on the need of the patient. But of course, that's a risk. So the company should really take a proactive role in order to define something better.
And again, it's the people who have the tumor lysis syndrome in the laboratory, those are probably not the ones you're worrying about because those are the ones who are responding. So you don't care if it takes you a while to get up to the maximum dose, you're getting a response, so you're not worried. It's the ones who don't have that tumor lysis syndrome that you may delay a month to get them to an adequate dose. So the question to you, have you seen, in the people who've used this, have they seen tumor lysis syndrome at 100, or 2? If they didn't see it at 1, so you have seen it like at the 100. So each of those steps, you've seen it if you haven't seen it earlier.
I don't know about 200 or 400 if you can see it earlier, but 100, yeah.
You have seen it 100. So at least going like, so you didn't see it at 20, didn't see it at 50, saw it at 100. But we don't know. So the question then may be, again, after 100, can you get up? Because that's one way to look at the data is how many patients do you see when they get to that next step that have tumor lysis? Because that'll tell you if 0 at the 200, then you can go right probably, from 100 to 200. That still saves a week, which may be.
Yeah. Though I have to admit that you don't know if you don't see at 200 because you stayed
gave
1 week 100, 1 week at
And
50.
you partially
So
debulked
you
them to a little bit.
diluted the effect. So
Yeah.
that's also another thing you don't know.
Yeah, but I think again, it seems.
No, but they
generally-
have to find a solution because otherwise doctors will find it, and I'm afraid of that. So.
And with how effective, FCR is, you don't see tumor lysis that frequently, and that debulks a fair amount of disease.
So Paolo, I have a question, and maybe a question for the other CLL physicians. Do you normally use a CT scan before you start your patients in normal clinical practice? And then the second part is, when would you do that with venetoclax? I'm just curious, do you normally use a CT scan?
Unfortunately, yes. Nowadays, after that we need to do it for clinical trials, so now became somehow a standard. Maybe not in the elderly or starting chlorambucil, but in young patients, definitely yes.
Certainly not been standard of care, but these trials that you had us do every 3-month CT scans, it's going to be a challenge to dissuade people from doing CT scans.
Now, what is true that, for example, we do CT scan before starting treatment. We don't do it every 3 months, definitely.
And we treat patients outside clinical trials, and we don't do a CT scan routinely.
Never, yeah.
So Paolo, explain to me, could you walk through how does it work for a patient who you're thinking about using venetoclax, right? So you do a CT scan,
Yes.
and then could you walk through that again? Because it seems like it's quite
No, but
cumbersome, is it?
for the staging, let's say, it would be exactly the same as you would do in other patients, except maybe in the elderly where if you start ibrutinib or you start chlorambucil plus rituximab, then you would not do any CT scan. But all the others, you would do the CT scan, you would do your normal blood testing, and then you categorize the patient. I think that the low-risk patient could, in the future, be treated as outpatient. I mean, you just keep. What I would suggest always is to keep the patient and for a few hours after they start the drug, check a couple of times the electrolytes and uric acid, and then they can go home. The high-risk patient indeed have the chance of lysing. So what we do now is that we plan when we want to start treating the patient, and then more or less in those days we try to find a bed. And then hopefully they have nothing on 20 milligrams, so they can continue being hospitalized. We do 50 and the treatment is finished. If you start treating the patient for 1 week with 20 milligrams, then you have to find another week, another bed. And for the high risk, you have to find it for 5 weeks every week. So that's a major thing. But I would expect that when you get up to 200, or maybe you don't see anything, even the high risk, you will be a little bit more flexible. And that's probably where the problem will arise.
Also, I think that obviously within the context of clinical trials, giving people high-dose steroids is something you wouldn't do. But, high-dose steroids can reduce the tumor burden and actually may obviate most or even all of this if you, in fact, did like 2 or 3 days of very high-dose oral steroids.
That's a good point, and I remember all this discussion because we have been so lucky to be involved in both the flavopiridol and daniziclib trial, so we have quite an experience with the tumor lysis prevention. The problem with steroids is correct, but then if you do it only for 3 or 4 days, then you have the release of lymphocytes in the peripheral blood, and then you find yourself with 100,000 lymphocytes in the peripheral blood. So either you do it for even 3 or 4 days and you wait longer, or waiting that the lymphocytes go back, or it's better to start directly with the drug. So that's only the issue. It is true that with the corticosteroids, anyhow, you are controlling the disease, so you might wait another week or 10 days until the lymphocyte count is back to normal, but that's a challenge, yeah.